I think we will get going. Welcome everybody to the National Primary Care Informal Discussion Group for Personalised Cancer Care. My name's Sandra Dyer. I'm Clinical Advisor for Wessex Cancer Alliance, and I'm pleased to host the meeting today. Can I have the next slide, please? So firstly, welcome to any new members. Just for a bit of context, this group meets every 3 months. It's an informal group where we discuss matters around primary care and personalised care in cancer. We welcome anyone to join this group, so please, if you've got colleagues who you think might be interested, please pass on the details of how to join, and that's via the website, which I'll share at the end. We are recording, so if you don't want to be on camera, please switch off your camera, and we will be sharing the recording on our Wessex Cancer Alliance website. If you are tweeting or Xing, whatever you want to call it now as a verb, can you tag Wessex Cancer Alliance, and the tag sign is there. Next slide. So just a few reminders, sort of housekeeping really. If you can mute if you're not talking, so just try and keep yourself muted, because otherwise it's really disruptive. Whilst people are speaking, it's probably best to keep your cameras off. It just helps preserve the bandwidth and picture quality. You can post any questions in the chat throughout. We've introduced something new today, which is the use of Menti, which we've rehearsed carefully. So we're hoping it's all going to go smoothly. But as with any technical things, there's always the opportunity for things to go amiss, so we'll see how that goes, but please do use the chat as well, and we've also built in some time at the end of the presentation for a little bit of sort of question and answers and discussion, so we hope to keep the interactivity going throughout. Yeah, so at the end, opportunity to ask questions, so either do it through the chat or you can raise your hand at the end for any questions. Can I have the next slide? So without any further ado, I'm going to hand over to speakers who are going to introduce themselves, but very briefly, they're to say they're from Transforming Cancer Services team for London. They're going to be talking about the Macmillan Quality of Life REACH programme, and it's Dr Philippa Hyman, Dr Fabienne Palmer and Mallory Jordan. So I'm handing it over to Philippa to start.
Thank you, Sandra. Can everyone hear me okay? Just wanted to make sure the sound level's okay. Great, okay.
Sounds good.
Right, so just to introduce ourselves, you're going to hear from all of us today. I'm Philippa Hyman. I'm the Associate Director for Personalised Cancer Care, part of the Transforming Cancer Services team. We also have Fabienne Palmer, who will be presenting as well, who's the programme lead, and Mallory Jordan, who's our project manager. So just to give you a bit of a brief overview today, and as Sandra says, we do welcome questions. We want to talk to you about a project that we started earlier this year. It's called the Macmillan Quality of Life and Personalised Care Community REACH programme. It's a transformation project. We were funded by Macmillan for 3 years, and we are hosted by the Royal Free. And we work very closely with the London Cancer Alliances and other key stakeholders. Next slide, please. So just to give you an outline of the session, we're going to give you a sort of strategic vision for our programme. We're going to talk about principles of equity and quality of life. We're going to talk a bit about kind of insights and engagement and what we've been doing about that, and kind of learning that we might have and you might be able to share with us as well. And then thinking about quality of life and equity and how that connects with primary care. And it would be really useful to hear your ideas from a primary care perspective. Okay, so just as a brief, some of this I'm sure will not be new to you, but just as a kind of bit of background on the cancer landscape. Cancer remains a significant challenge in the UK. It has a huge impact on individuals, the healthcare system and the economy. The cost of cancer to the UK economy is estimated to be about 7.6 billion a year. As an ageing population and advanced cancer treatments, there are more and more people living with cancer. So we sometimes think of that as people living with cancer as a long-term condition. So you will see more and more people with cancer within primary care. In London, the cancer population is likely to double by 2030, and we know that there are about 1 in 4 people living with the long-term consequences of cancer. And really, what we feel very strongly about is that attention must be focused on experiences of quality of life for this growing population. We have, as people will know, very much an emphasis on diagnosis and early diagnosis and screening, and not so much on personalised care. And the promise of personalised care is not happening for everyone, and we think not equally. And we know that from a lot of data. So this project is really about how do we create equitable personalised care. So we need to understand who's missing from the conversation and why. And we do know in London that when we look at a number of different surveys and interventions, there are underserved communities we just don't hear from, or hear from in a very limited way. Next slide, please. So this project is around how we can understand what quality of life means for underserved communities following a diagnosis of cancer. And we want to really inform a more inclusive, equitable and relevant service design and delivery of personalised care. And what's really important about this is we know that access at the moment is pretty unequal. We know there are worse experiences and outcomes for people from underserved groups. They have much poorer quality of life, and there's much more pressure on the wider healthcare system. And actually their outcomes are generally much poorer in terms of kind of mortality. The programme we've been funded for by Macmillan is quite an innovative programme. It focuses exclusively really on quality of life. It covers all of London, and we are really taking an anti-racist and social justice and inclusivity approach. We're putting people and communities at the heart of what we do. We're really wanting to make sure we have really good engagement. We're trying to use data to guide our decision making, and we're wanting to work with all parts of the healthcare system. And that's also why we're really interested in hearing about primary care and your ideas about this. So just as a sort of summary, the problem we see is that we don't understand what quality of life means for people from underserved communities. We don't have a good way at the moment to gather feedback from these groups. We know we have the Quality of Life Survey, which was rolled out by the National Cancer Team a couple of years ago, but we do know when we look at the data in London, and Mallory will talk a bit more about this, that we actually are not hearing from communities we would expect to hear from in the numbers we would expect to hear. We're hearing, I think, predominantly from kind of people over 50 who would identify themselves as white. And the danger of that is that you can wider inequalities, because if you actually then commission services based on who you're hearing from, we're not hearing from a representative sample of London. So we have got opportunities here in this programme to understand what quality of life means for underserved groups, to kind of co-design much more of an equity and anti-racism informed approach to personalised care. And we want to make sure that we have recommendations that can create change at multiple levels of the system. And we hope that the impact will be that there's improved quality of life for people, improved uptake and engagement and experience of personalised care interventions, better equity of care, and I think an increased NHS awareness about how you actually implement much more practices that are driven by equity. So people with lived experience in communities will be at the heart of this project. So I think before I hand over to Fabienne, I know I've whizzed through that. I just wondered if anyone had any initial questions about that, about the project and kind of where we're starting from. Okay, we can move on. What do you think, Sandra? Should we move on?
Yeah, and move on, I think. Yeah.
Brilliant, thank you. So we've mentioned the word equity and quality of life several times in the course of our presentation, and we do this, you know, as these are principles and aspects of the work that are really important. But what we wanted to do is to, before we go into a bit more of a deep dive of what those terms mean to us, is to explore what do they mean to you. So this Menti is really designed to kind of capture anonymously the views of everyone on the call. So if you can, please use a device that allows you to scan the QR code that's on the screen. You can also go to menti.com and use the code that is on the screen, which is 76751792. Do we also have the link for the Menti in the chat? So that if at all you are unable to access the Menti through either of those measures, then you can join the link instead. So we'll just take a few moments just to see what comes through. But also, if you wanted to unmute yourself, if you wanted to share what comes to mind in the form of a kind of discussion, we can also do that. But we wanted to give space for some initial ideas to come through.
I can't see the link in the chat. I don't know who was popping it on there. Was that you, Mel?
Oh, it's just, sorry, it's just on its way in. Is that? That's
all right, thanks.
No worries. So we've got on there social justice, fairness, comfort, health equality. That's fairness is getting pretty big. So if you've never used Menti before, the words that are biggest on the screen are the words that have been used the most frequently. So there is a consensus around fairness being, you know, very relevant to these kind of two different terms. Contentment, meaningful, no postcode lottery, personal, included. Wow, these are some really good words, actually. They're really connected to some of the things that we've been thinking about as well. Does anyone want to share any kind of initial reflections of what it meant for them when they saw this question? There's no right or wrongs, by the way, just a kind of reflection of what it means to those of you on the call. I can see a hand is up. Is that? I couldn't see the name, sorry. Did you want to unmute yourself?
Sandra Smith, West Midlands Council Alliance.
Oh, hello, hi.
Hi, just to say what it brings up to me is these, you know, these ongoing conversations, and it feels like it's something that we may continually have to be trying to resolve, and it's something that, you know, it's how long is a piece of string, but it's something that we really all need to be involved in, and it's a continuum, not just a project that will come to an end, and it's the right thing to do, and that we're forever evolving and changing, and needs always change. So there's unmet need, unknown need, and the needs that we identify, and I think we really have to just press on ahead with the agenda continuously. I should put my
Absolutely. Thank you so much for sharing that perspective. I think, again, that really aligns with a lot of the kind of dilemmas and challenges and also opportunities for this programme, because it is only here for kind of a short period of time, 3 years. It will whiz by very quickly. But what we're thinking about is sustainability and the end, you know, at the beginning. How do we make sure this stays on the radar? Whose voices are not being included? How do we ask difficult questions? How do we kind of think about what it means when times change, when things are kind of moving in different directions? So yeah, there is a kind of really important thread there in terms of keeping that conversation going. Any other thoughts, or should we?
Kathy's got a hand up.
Oh, sorry, I can see Kathy. Would you like to say?
Hi there. I'm Kathy. I'm Macmillan Living with Cancer Programme Manager in Lincolnshire. Very different place to London, very rural, coastal communities. What struck me thinking about quality of life is that everyone's measure, every individual's measure of the quality of their life will be different. And equity is about enabling everyone to achieve the quality of life that they would like to achieve in their different ways.
Absolutely. I think quality of life as a concept, we've had many conversations about this as well, that yeah, like what does it actually mean, and who does it mean it to, and who gets to decide that? But also, how do you facilitate and ensure that people, you know, can make decisions, access support, access what they need in order to really, whatever their definition of quality of life, to be able to kind of access that. So thank you again for bringing that perspective. So there's some really interesting and powerful stories and insights that are coming through, which makes me really excited to also share some of the ideas that we've been connecting with over the course of this programme. So I'm going to share a couple of images that you'll see on the screen, and thank you to everyone for what you've also contributed so far. So when we're thinking about this image on the left, we feel like it is actually quite important to make you know, some very clear distinctions between some of these terms. So firstly, the idea of equality. So equality from how we've kind of defined it and what we've drawn upon, is about treating everybody the same, so giving everybody identical resources or opportunities. And while well-intentioned, equality assumes that everyone starts from the same place and everyone needs the same help. And what we can see in that image is that that isn't the case. Then comes equity. So equity recognises that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. So that is about fairness, it's about justice, and making sure that everybody ends up at the same level. So we've included a couple of other ideas on here. So liberation goes a little bit further, and this is about dismantling the barriers that create an inequity in the first place. So that's about how do we remove systemic obstacles so that everybody can thrive without extra support. And inclusion is about ensuring that everybody feels welcomed, valued, and integrated into a group or society. So it's not just about being present, but about being actively involved and respected. So we have prioritised equity as a vehicle for liberation and inclusion. We see that that has a really pivotal role because we recognise that without addressing the specific needs and the barriers faced by different communities, we cannot really achieve inclusion or true liberation for all. So we have got on the other side an image which we feel really helps to illustrate this in terms of responding to multiple kind of fires and multiple issues. So when we think about our focus from an equity standpoint, we've been thinking that we need to prioritise the fire that is biggest first, in the same way that a fire engine, if there's a fire on multiple streets, would also do that to prevent the most damage. We're also thinking about how we focus our resources where they're needed the most. They then protect the entire city more effectively. So in our programme, we're prioritising ethnicity as a vehicle for addressing multiple challenges at the same time, and recognising that that's where, when we look at the data, we see the most significant challenges and the most significant inequities. So by focusing on the communities that face the most significant barriers due to systemic inequities, we can then think about the solutions that are going to uplift everybody. So then, how does that link to this image here? So we've been thinking as well about this concept, which is intersectionality. And this is a framework for social graces. Some of you may have come across this idea already. But intersectionality is a framework for understanding how different aspects of a person's social and political identity. So just like here on the social graces, there are the graces bit is an acronym for all of the kind of different aspects of a person's identity. But all of those things, when they combine, create different modes of discrimination and different modes of privilege. So these identities can include things like race, gender, class, sexuality, ability, and more. So we know that, for example, the experiences of somebody who is like a Black woman cannot be understood solely in terms of being Black or being a woman. There is something quite unique about that intersection and that overlap of possessing those two identities. So by embracing intersectionality, what we're trying to ensure is that our programme doesn't adopt a one-size-fits-all approach, but we do consider and recognise that there are complex and overlapping factors that affect people's lives. And that includes us being able to then think about more creative and effective inclusive strategies. And it is important to our work because it highlights the necessity in addressing multiple forms of inequity simultaneously. So we know that no one is then left behind and that our efforts do contribute to some of the goals that we spoke about at the beginning of the programme. Thank you. So in terms of what that looks like in a kind of practical sense, we're thinking as well about how we use an approach which is called asset-based community development, and how that essentially allows us to focus on the strengths and the potentials of our communities rather than their deficits. So when we engage with people that we don't hear from, seeing them from that perspective, we know is really powerful because it empowers communities to take control of their own development. It builds on what they have and respects their capabilities. It also recognises their capacity of growth and that growth being meaningful and sustainable. So we are implementing this kind of approach to ensure that we collaborate with people at different levels of the system and that we model genuine partnership working as a way of addressing and solving some of these really big issues in terms of equity. I'm going to hand over to Mallory now, who's going to give us a little bit more of an overview of some of the insights and the data that has supported our understanding so far.
Awesome, thank you, Fabienne, and hi everybody. My name is Mallory, and I'll be providing an update on what our program has found so far. So we have done a current state analysis, which has been produced in a report form. And the reason why we did this was to understand more about what is currently going on in the system and what has led to the current state. We believe that this has been a good use of time, as it will set the foundation for the future direction of this program, including it will help us understand bright spots in the system, key learnings and gaps, help us to create value, help us understand that the system is very complex, so having more of an idea of what has been done will help us to avoid any duplication, celebrate strengths of what has already been done, and provide further clarification on key deliverables. So this report focused on four key sections, the first one being the historical, economic, political context, where we looked at the key drivers that create inequities today. The second section looked at strategic drivers within the NHS and the system. We did a data analysis into key interventions and surveys within personalised cancer care, which included the EH&A, the NCPAS, and also the Quality of Life survey. And lastly, we did a review of projects in the system, both inside and outside of cancer. So we have connected with 56 system leaders and also 70 literature and project reports, where some of the key themes that came out of this was that there are some key groups that are most impacted. This includes Black and Asian, where they yielded the lowest response rates in the Quality of Life survey, younger adults and older adults, as well as those in the most deprived areas. We wanted to focus more on the Quality of Life survey in today's presentation, and the data here illustrates key statistics for London, where it shows Black patients and Asian patients have the lowest levels of engagement when compared to their counterparts. Younger adults under 50 and older adults over 80 have the lowest response rates, and also those in the most deprived areas have the lowest response rates. There are multiple reasons why people don't respond to the survey: assumptions around digital literacy, the beliefs and assumptions behind the survey, not understanding the need of it and where it's coming from. So that is kind of our next point in our engagement phase, is to understand why patients themselves, understanding why this is. So our program looks to hear from underserved groups across London. What we have done so far is focused on our patient and public voice partners, also known as PPV. So we're looking to create a sustainable, accessible and inclusive way to value people and their lived experience for their time and inputs. We have also been working on a logic model co-design with both stakeholders, our steering group, and also patients with lived experience to help us design the program plan. And as we progress, we continue to build relationships across the system. But as we all know, with representation and engagement, many of us face similar challenges. This includes building trust, moving from talking to doing, moving from interest in the program into actually engaging with the program, inconsistent, fragmented and inequitable PPV processes, and also the evolving and changing cancer landscape, which includes national strategies, changes within the Transforming Cancer Services team, and also big changes with Macmillan Cancer Services, who is the lead funder for this program. So far from the conversations and insights we have gained from different levels of the system, some ideas about how this program could add value include the following outputs. So people have come together in the co-design session, and some of the key themes include working with underserved communities to develop a primary PCC equity framework, also a new engagement strategy, new ways to hear from underserved communities rather than through surveys, a data strategy, creating consistency and transparency across personalised care, an engagement report looking at what does quality of life actually mean for these underserved communities as well as the wider system, educational resources, what quality of life means, again, at the different levels, and also a new PPV approach that is equitable, consistent, and efficient. So our hope from now until the end of the year, we have both an in-person session next week and one-on-one conversations with individuals who identify as Black or Asian ethnic groups and who also identify with one or more of the following intersectionalities that we have touched on today, including older adults, younger adults, and individuals who live in areas of high deprivation. Our hope is that a key outcome from these conversations is that we will be able to draw on their insights to further develop the final program design and delivery.
Brilliant, thank you. So we just wanted to take a pause because I know we've shared quite a lot of information, a lot of data. So initially just to see if there are any kind of thoughts or ideas about what's been shared so far, or any questions. But also thinking about the last point around representation and engagement, what we've really centered this program around is how we make sure that we've got the right people around the table that are able to kind of inform the service delivery and design in a way that is representative of the diverse needs across London. And there are challenges in doing this. So we are really kind of interested in also hearing from you about what your experience has been of working in partnership with communities that are underserved according to your local areas, recognising that that might look very different at different phases of somebody's journey, but also that there may be loads of similarities as well. So we're really curious, really interested to hear if there are any wider questions that people had about the data or reflections or insights, but also about representation and engagement as an approach to change.
Thanks, Fabienne. Maybe while people are filling in the Menti, there's a couple of questions in the chat, Fabienne, if you just want to take a peek at them.
Oh, brilliant. Let me just have
I can read them out if you can't see them.
Yes, please. Actually, that might speed it along, but I can't see them. Sorry.
Okay, so I guess it's more of a comment, but it's a kind of a question, I think. So Jackie says it's important to understand the difference between equality and equity, which I think you might have covered. But there's a follow-up bit saying equality is so much more than protected characteristics of the Equalities Act. This is a Human Rights Act, states we cannot discriminate for any reason. So I don't know if Jackie wanted to kind of chip in and kind of just elaborate her point, or whether you think that's been answered.
Yeah, no, really, it's been answered, because the slide afterwards, I was writing that comment before I saw the next slide, which was the great excess one, where you did actually capture things like, personal characteristics. So you can't discriminate against me because I've got blonde dyed hair or I wear glasses. So it's more than just those protected characteristics. So thank you.
I think it definitely taking the time to kind of explore what these kind of different terms mean and their breadth and their complexity and their nuance, but also the kind of straightforwardness and simpleness about them as well, that actually we can't discriminate against people based on any characteristics, and actually we do need to think about each other as resources, think about the value of being different, what we bring because of our perspectives. So seeing the kind of the strength of that. So I can see that there's some responses as well coming through on the Menti. So one of them I can't read entirely, but I'm going to do my best. So thinking about identifying champions from underserved communities, utilising inlets such as religious individuals within their community they trust, need to build trust, engaging with leaders of the community, We cannot understand the community. They need to inform us. Yeah. Sorry, brilliant. Thanks, Mallory. Identifying communities using population health data, and then taking a co-production approach to think about the barriers and the challenges, and also building up confidence to engage. So there is definitely a wider narrative that we've also come up against as well, about the kind of mistrust of organisations and people coming in and doing short-term pieces of work and disappearing, or the kind of, how do you embed and sustain initiatives? How do you share the kind of responsibility, or the idea of ownership? Who owns what and why and how? These are also really kind of important conversations. So I can see there as well, there's been something about co-production and ownership being really important. How do we all kind of see this as aspects of our responsibilities, but things that we might benefit from or lose out from if they're not kind of addressed. So there's really some very interesting ideas that I think really align with some of the reflections that we've had along the way. I'm just kind of also looking to my team and thinking, are there any other points that you would make based on what's been shared so far, or that haven't been shared already about representation and engagement?
Yeah, I mean, sorry. Yeah, apologies. I think it really connects with a lot of the things that we've noticed. I mean, I think one of the things we're really aware of is that people with lived experience do get asked a lot of things, and often it gets repeated, and often there's a sense that what happens as a result of me completing a survey or communicating. So I think one of the things we're really mindful about doing is not duplicating, and actually trying to ask questions perhaps that haven't been asked before, or asked in a different way, and actually engaging with people in a way that feels quite a different experience. Because I definitely think we've had a sense that, if you look in the NHS, there's quite a lot of surveys and things that are actually asked of people, and people don't always hear what the outcome was, or feel there's any sense of action or anything happening as a result. So we're trying to also think a lot about how we do things a bit differently with this programme.
Absolutely. I can see that there is a hand up in the chat. In the room. Are you happy to unmute yourself?
Yeah, sure. It's Jackie Graves here again. Certainly when I covered a long time ago now the Macmillan Development Manager post, as it was in those days for Slough, we had a community outreach person who actually was recruited from the Bengali community, and who spoke a number of dialects. So actually engaging those communities, because she came from within the community, was able to talk to them obviously in their identified primary language. That made a massive difference in terms of actually getting them to better engage, I guess, with cancer services at the time. And I think there's been a lot of different versions of that over the years, having worked for Macmillan for many years. But obviously it's about the funding, and invariably the funding is for a 2 or 3 year period, which is a bit like what you've got at the moment. And then when that funding goes, it's not continued, even though there's been great learning from it, and it has been a great way to engage with those communities who are so underserved.
Absolutely, you've really spoke it. I mean, it sounds like you've got so much experience, and really have been involved in some very powerful initiatives. And that is something that we've also come across in our work, that there's so much value and emphasis placed on engaging the right people, having people who are already connected to communities, seeing them as true partners, and actually wanting to make sure that that is something that can be sustained, thinking about how we treat people in the short and long term, but also what sorts of messages we might be communicating consciously or unconsciously, inadvertently, or otherwise, about the value that we place on kind of really connecting from and hearing from people with lived experience, and people who maybe their first language or their preferred kind of language is not going to be English, or maybe there are other kind of aspects to communicating or ways of reaching or engaging with people that are going to look very different from a survey or from sort of national or traditional approaches. So there's a lot that's kind of being thought about around that, and also the complexity of then how do you aggregate or collect or make sense of all of that data and those insights, if we're kind of using them in lots of really responsive ways, but also make sure that we're really clear about what we're asking, why. We're really clear about when we've collected that data, that we do something with it, that we use those insights or we make sure that it doesn't end up being very repetitive, that people say what they want and need, but nothing is action. So there are a lot of risks and challenges there, but I think it sounds like there's also a lot of really brilliant work that's already taking place to try and address that. So that's really encouraging to hear. Are there any things in the chat that I can't see the chat at the moment, but any things that would be useful to pick up as well?
No, there isn't nothing else in the chat at this point. I had a quick question, if I may. So it's around looking at other kind of programs or disease areas, for example. So I'm thinking particularly about HIV, where there's a kind of really well established of kind of health activism and advocacy. I think there's so much to be learned from the history of that disease and how people got together to kind of support themselves, but really kind of influence policy and change as well.
Yeah, Sandra, I think that's really useful. I mean, one of the things we did early on with this project is not only looked at what we can learn from within cancer, but certainly outside of cancer. And I think HIV was one area we found out about a project actually in Southeast London where they've used, again, champions from underserved communities, particularly around treatment adherence. And it's been a massive impact having somebody from those communities connected into kind of the MDT, but also those communities. And it's hugely had an impact on uptake of treatment for people that were just absolutely disconnected. So we've been really trying to think about where we can get learning from. You know, we thought about mental health, we thought about, there's been work in diabetes, maternity. I saw what Jackie, you said in terms of sickle cell, absolutely. So yeah, I mean, I think this is really important in our project. I mean, one thing we're also mindful about is scope. We're very, very mindful of what we need to do for this project. And just the other thing connected to what Fabienne was saying is we're really keen to think about sustainability. This shouldn't be a project. I can't remember who said that earlier. You know, this is what should be business as usual. This shouldn't be, here's a project doing something interesting for 3 years and, that's it, goodbye. So we absolutely are thinking now who we need to be influencing, who needs to be key players within our steering group, within the conversations we're having, so that we can really make sure that the findings and the kind of recommendations have an impact, and that it isn't just that, oh, that's an interesting project and it kind of doesn't sit anywhere or land anywhere. So that's very much part of what we're doing as well within this project.
Absolutely. I mean, it brings us on to kind of thinking about what are the opportunities within primary care. And I suppose we're saying that from the broader perspective. So as Philippa mentioned in terms of scope, but we do have to be very mindful of the experience of scope creep and like wanting to fix and address everything, but also thinking about principles that might unify, lots of different pieces of work or different ways of kind of addressing very similar challenges. So what we wanted to invite you to think about in your capacity, whether you're kind of from a sort of in relation to cancer and personalised care and equity, what kind of role do you think that you can have in supporting someone with cancer, that particular part of their journey? You may be drawing on different experiences, different knowledges and different insights, but what do you think primary care could be doing or is doing or could be doing more of or less of in order to really promote quality of life and in a way that also embeds principles of equity or has equity at the centre? Michelle, I can see that your hand is up.
Hello there. I'm a social prescriber and I'm the non-cancer clinical lead for Southampton West PCN. And in our role, it's all about patient-centred care, as we all do. But we have a specific role as social prescribers in our PCN where we do work with the cancer patients. It's the first review after they've had a diagnosis and the 3-month review. But as part of our work, we're all about, as we all try and do, but our focus is the holistic approach, is what's important to them and what do they need. So it may be about thinking, how can you engage with people in primary care who are not necessarily clinical, but are also have a role in the communities to play?
Thank you so much for raising that. And I think we've had conversations with social prescribing, kind of thinking again about the range and the reach of different roles and and different parts of the infrastructure that really need to be involved in these conversations. We can't just kind of think about it when we talk about, diagnosis and treatment as only being in an acute kind of context. It is the whole system that needs to be involved, and the learnings again, and the connections, and how do we make sure that we're overlapping and we're working strategically in a way that does build partnerships, but that they're long term and not just because there's an initiative that's taking place. So that's really helpful to keep that on the radar about social prescribing. Thank you. Joyce, I can see you. Sorry, I can't see which order people have put their hands up in, but
I think Tanya's first,
Tanya,
I think, and then
sorry,
Joyce.
Tanya, would you like
Hiya, thanks for that. Yeah, I think the primary care aspect is so important, because if we are going to achieve this target of diagnosing 75% of people with cancer at stages 1 and 2, that means 75% of people with cancer are going to be living with long-term effects of possibly treatment, but just the whole impact cancer diagnosis has on your life. And yet we don't really put any kind of resource into enabling primary care to support them going forward. I think somebody just made the point that often cancer's thought of as a secondary care thing, whereas actually people with cancer are spending more time in the community than they are in hospitals, and yet all the focus is around early diagnosis, treatment, but not living with and beyond cancer. So just a sharing of frustration really that I think other people have mentioned.
Absolutely. Thank you so much for raising it. I kind of want to look to Philip as though this is something that you've definitely championed and spoken a lot about as the Associate Director for Personalised Care in London. But is there anything that you wanted to kind of add in response to that?
Yeah, I mean, I keep coming off mute. Sorry, I don't wish to do that. Yeah, I mean, I completely agree. I think that there is a huge focus on the kind of acute secondary care and not what actually happens, when treatment ends, or when people are living, as I said, for many people now, treatable but not curable, living with cancer and its consequences. Living with cancer is a long-term condition, and I think that people haven't really caught up, I think, in many ways with that and what that's going to look like. And obviously the new 10-year plan, talks a lot about how we need to move a bit more from acute to primary and community. We've heard that a lot, haven't we, historically? I think we have heard that narrative. It'll be very interesting about whether there's a bit more detail on, what that will look like and, what resource might be attached. Because I completely agree. And if you talk to people with lived experience, lots of people will say to you they feel very contained whilst they're having treatment, but it's absolutely what happens afterwards. And I think that's what we're told constantly from people. So I think this is a really key area. And finally, if you look at the quality of life survey, which was rolled out by the national team, that was a survey that is given to people 18 months after diagnosis. And the majority of people will have finished their treatment by then. That was why that 18-month time point was selected. So I think you do then need to think about, what services are supporting people at that point in time, including primary care. So I think this is a key issue. It's kind of the narrative's there, but I'm not sure it's being backed up by necessarily what we need in terms of kind of resource and a bit more clarity on it. But I can see someone else's hand is up, so I'm going to be quiet. Sandra, let you go to that.
Yeah, Joyce, please.
Hiya. Yeah, I think I'm just echoing what the others have said, but I think now working from the secondary side and have been working in primary care, I think the link between secondary and primary care is still a big gap. And to have that seamless transition of patient, and how could, I think we need to empower primary care as well, and that should be coming from the secondary care. So you have the seamless transition of patient and the communications and the cancer care review and everything. Meaningful cancer care review is not, I think there's very, very low uptake of doing a meaningful cancer care review. But if you look at the cancer care review performance being done by primary care, it's always 100%, but there's no meaning, and it's just a tick box exercise. And I think we need to support from both ends and closing that gap in terms of personalized care, in terms of supporting post-cancer treatment, because I think there's not much money for supporting post-cancer care. There's so much money pouring into screening and everything, but post-cancer care, there's not much attraction we're getting in terms of supporting. So yeah, that's just me. Thank you.
Thank you. Yeah, I think what you're describing about that need, again, it's like partnership working. What does that mean, and what does it look like in you know, within the systems that we have in a kind of clinical or NHS context? But yeah, like who needs to be involved, and how can we make sure that people don't fall through the gap, that the systems are talking to each other, and people do have a much stronger role in directing their care as well, having a stronger voice and being able to say and advocate for what they need and then be heard, you know. Can see that there are some comments in the chat, but also another hand was there another hand that was raised?
Yeah, there is. The comments in the chat kind of relate to the point that's just been made, so it might be good to pick them up first and then go to Becky, if that's okay. Do you want me to read them out?
Yes, please. Yeah.
Yeah, so Jackie notes that QOF income's protected this year, so whether or not practices do their cancer care reviews or not, they get paid. So that's not particularly helpful as a lever. And then Heather in Manchester has just said that Greater Manchester have just done a big project on improving the quality of cancer care review in primary care, making them more meaningful and equipping more of the workforce to undertake them. They developed some good resources, just done a webinar to educate on these. So that sounds really interesting. And Heather, I'll be reaching out to you to see if you want to present that work at a future meeting. So I think it'd be good to share with the group.
Really, that sounds like really interesting work that's taking place, and I think a big part of some of the stuff that we're thinking about is how can we stay connected to the developments in this area and promote it as well, or kind of draw on it to support the work. I can see that there is also, should we go to the person?
It's Becky.
Yeah.
Hi, I'm primary care nurse facilitator down in Sussex, and yes, I just wanted to jump in on what Joyce said and what's been in the comments as well. So my role is to improve cancer care reviews on a very basic level. So I think not only highlighting that within QOF, the cancer care reviews and the 3-month supported discussion are now income protected, but unfortunately that has also led to a misunderstanding around, with GP partners in particular, believing that therefore it is no longer a requirement and they no longer need to do them. So we've seen a huge drop off in them actually even happening in the first place because they're being paid regardless. And a big area that we're looking at is that communication between services. And I think what we're finding is incredibly difficult is that even within primary care or just secondary care, a lot of services do not share a record keeping system or a way of communicating. So we're currently doing a big work around end of treatment summaries and ensuring that A, they're being written, but B, they're also being shared out to primary care, and C, they're being used to inform good cancer care reviews. But the logistics, purely from a digital point of view and that communication point of view, are just unbelievable. The actual template itself, easy, but how that communication happens and getting different services and areas to understand that when you do a wonderful H&A in secondary care, that is in no way shared out with general practice, and that doesn't in any way inform ongoing care. I think often what we're finding in our conversations with people is that they believe that they're doing these assessments and documenting them and somehow they are being shared, but they're not at all. And the frustration that patients also experience when they feel that they're having to navigate these really complex systems and having to retell everything all the time, and that GP practices are just not aware of what treatments happened. So I think these are all, you know, really important things that need to be looked at nationally rather than in the little isolated pockets that we're doing. You know, like, it sounds like what I'm doing down here in Sussex is happening up in Greater Manchester, but what we need to do is actually look at it on a national level.
Absolutely. I don't know if there's anything.
Yeah, I mean, stupid, I still don't know. I totally agree. I think there's a number of things of the things that are arising within our project where, you know, we are linking in with the National Cancer Team and the Living with and Beyond Cancer leads. I think there is going to be that influencing strategy around all sorts of things that we think would be sensible to be implemented, because we're not going to be able to deliver within the lifespan of this project. And I agree. And I think, you know, a lot of these are challenges we've known about for a long time, but I do think we need to think about, you know, where things need to be thought about, who needs to do what. And obviously, these things are even worse when you think about the equity lens that we're using for this project. You know, it's not great for anybody, their experience of cancer care reviews, for example, and communication between primary and secondary care. And it's even worse for a lot of the underserved communities we've talked about. So I kind of think, you know, that's the kind of context I suppose we're thinking about.
Tanya's got her hand up.
Yeah, thank you. Sorry, just wanted to make another point really around duplication. And that I know in the community there are lots of sort of cancer care coordinator type roles. Obviously in secondary care there's a support type care role. But we know that there's so much duplication with the different people doing the same kind of thing. And I'm sure there's lots of patients that get multiple offers and then other patients that don't get offers at all. And if only we could find some way of resolving that duplication, you know, sort of trying to join the primary care and secondary care resources together to offer a much better service to a lot more people.
Yeah, helpful.
Thank you for sharing that that insight. It does feel like there are, you know, multiple kind of barriers, and going back to this idea of you know, equity and liberation. You know, it's still thinking what are our roles. It sounds like everyone's working really hard. What are our roles in making sure that what we're doing is visible, that we're connected in, or that there's kind of opportunities for shared learning. And again, it's this theme of partnership. How do we see each other as partners and know that we have got you know, resources, strengths, excellent ways of doing things that we can learn from each other, untapped, unknown. You know, I really liked actually the kind of different terms that we used a little bit earlier on, but essentially how can we kind of know and learn from each other in ways that benefit the whole system, and continue to do that, not just you know, because there's a project, but you know, see it as business as usual. So I think it's given us a lot of food for thought in hearing those perspectives today, those insights and those dilemmas and challenges, but also really exciting to know and hear like what other people are doing. And one of the kind of deliverables or outcomes that or outputs we were hoping to also, you know, think a bit more about is how do we, when we learn and we hear about different projects and pieces of work and initiatives that are taking place, whether that's in London or beyond, how do we capture them and give that back to the system so people can connect with each other as well, and kind of, you know, see each other as a resource. And again, who owns that and sustains that when we're not there? Is there a demand for that? Is there a need for that? Who, you know, who can we draw on to share some of those kind of insights? So I guess that sort of, from thinking about the time, you know, we could probably have a really long conversation about this really, but if there are any final kind of thoughts or questions, we invite you to share them with us. But we also have a QR code, and we're sharing our email address. If there are things that you would like to pick up with us offline, the QR code will take you to a site that asks you to, you know, just share any feedback about the session today, but also if there are any particular ways that you'd like to support or be involved in the programme. A few options on there already, but if there's anything that hasn't been listed, then we really welcome you to kind of tell us what you need or how we might be able to support, because we don't want this to just have an impact at a kind of local level or regional level. We're thinking about the generalisations within cancer and also outside of cancer in London and nationally. So really thank you so much for your attention and engagement today. It's been brilliant. Thank you, Sandra, for inviting us to be part of this conversation today. Yeah, any final questions, please do send them over and we'll be in touch.
Well, thanks, Fabienne and Philippa and Mallory. That was great. I'm just wondering, it'd be good to hear how your project's progressing, and maybe to come back sometime next year with an update would be great. To see perhaps how
Sure.
you've started tackling some of those issues. Couple of themes that have come up in the chat and in the discussion. One being around sort of information sharing, data sharing. So I think that would be a really good topic for a future discussion group. So I'll be in touch with people that have put their emails in the chat, and maybe it's something we can bring to a future meeting. And also the CCR work in Manchester would be great as well. Our next meeting's the 18th of March. Hopefully you've got invites in your calendars. If not, let me know. So we do need speakers for 2025. So aside from what we've talked about today, if there's any other great work that you either know about or are leading or got colleagues leading, please get in touch and we can schedule you in for 2025. Recording for this will go onto the website, and I've included the website here. On that you can also see kind of previous recordings all the way back to when we first started recording about 18 months ago. So lots of stuff to dip into around personalised cancer care in primary care. And we have got a flyer as well, which I'll share, which you can then pass on to colleagues. I think we've got 4 minutes. So if there was anything anybody else wanted to kind of chip in, now's your chance. If not, I'm going to Sandra.
Can I just take the opportunity to connect with Heather from Manchester? We're setting up a cancer care working group looking at improving and standardising the delivery of cancer care reviews in primary care. So would it be possible for me to connect with you and perhaps have a discussion about some of the work that you've done in Manchester, please? Heather, has she gone?
I'm not sure. If not, Heather's left her email, I think, in the chat. So I suspect you could just drop her a message.
Yes, I will do. I will do. I've done that anyway, but I just thought, yeah, I've done that anyway, but I just thought I'd give her the heads up.
My mic wasn't working, Sandra. I'm very happy. I have put in the chat. My mic wasn't working. Yeah, very happy to connect. I think I can put my email in the chat if you like.
No, I've picked it up from your previous discussion, so I've picked it up from the chat. So that's great. But just to give you the heads up, I will be contacting you. Thank you.
No problem.
Good. I like to see these connections happening. That's what we're all about. Okay, if there's nothing else, wish you all a good sort of festive period, and we'll see you again in 2025. I'll be in touch with those of you who have kind of popped your emails in around potential talks for next year. And as I said, anybody else who wants to present, please get in touch. Thanks, everyone.
Thank you.
Good to see you all.